So Shubhra got allotted at GMC Jammu and she's awaiting for an upgrade. Fine. Yeah, so it's time. Hi everyone. I don't know if I need to say good evening or good night, but this is kind of the surgeon's time, something which is going to be very regular for you. The 11 p.m. midnight calls is what I say because this would be the time you would get free after majority of your ward work, after your rounds by your senior, second years and third years, somewhere around 8 to 9. So you'll be getting like 2 hours to wind up everything, and probably this would be the time, like 11 to 12. You would sit down, have your dinner in your first year, and then maybe do some more work, the leftover work for another 1 or 2 hours, and then you would catch a sleep at around 2 o'clock. So, welcome everyone, and thank you so much for joining. For those who don't know, and I'm very sure most of you people don't know me, I go by the username of to something great on Reddit. And the first post I created on Reddit, the Ask Me Anything on the Reddit sub, was basically out of boredom, I'd be very honest. So currently, I'm at my hometown Ranchi and I'm preparing for my SS super specialty exams. And I'm Dr. Ayush Bhadani, and I did my undergraduate from Arjikar Medical College and Hospital, Kolkata. I passed out in 2022, and then I joined AIIMS Patna. There was a huge fuss and commotion and sort of dilemma regarding joining a central institute versus a state institute when I was selecting the colleges. So what really happened was that my INI counselings were happening before the NEET counseling. So I had gotten AIMS Patna through INI, and so I just took it with the thought that probably I was sure that I would be getting most of the colleges of general surgery except maybe one or two in Delhi. So my first choice was Grant Medical College, Mumbai, and I was getting it for sure. So I went there. I had seen the campus. I had spent 2 to 3 days in their emergency, and I was sure that I would be taking up Grant Medical College and Hospital, Mumbai. But later, when I joined in AIMS Patna, the first month, second month, third month of residencies were too amazing and too good. I kind of started enjoying the residency, my hostel life, my friends, and then with a lot of discussion and debates, I finally stuck to AIMS Patna. And this is the one decision I never regret, and I'll never regret again ever in my life. So I also happened to just complete my MRCS Part A by Edinburgh, and I write something known as a PG Mass Fellow, and I tell you what it means. So PG Mass is something like a minimal access surgery fellow, which is a degree which is provided by the IAGES, or the Indian Associations of Gastroendoscopic Surgeons. I also happen to be a TISA winner, so I'll also talk about a little bit on TISA, that is the Torrent Young Scholar Awards, which is a yearly sort of an exam or a competition which is conducted by the Associations of Surgeons of India. And this times the finals would be happening at Kolkata at the ASICON, probably 18th to 22nd of December. And so after winning that, I went to Japan. I did an observership for a month, and I also speak a lot on that as well. I also do a lot of medtech and innovation. So I'm full time into AI device innovations, and I keep on taking sessions on how to use AI, artificial intelligence, using GPT, etc., in solving and making your life easier. So yeah, welcome everyone once again, and so I would love this to be more of an interactive session. And in this next 40-45 minutes, we try to understand things which I wish someone had told me before my day one of residency. We'll try to know what actually matters in residency and how do we survive, grow, and get the most out of these 3 years. I'm very sure, as most of you have told, that you all are very much scared for the fear of not knowing enough. Some of you are also worried for the seniors' toxicity. Some of you are worried for the sleepless nights and night duties and workload and stuff. But no one is worried for doing the surgery yourself. So that basically gives a good picture that all of you guys really want to do surgery and you're not afraid of doing the ORs. So this picture here is of my co-JR. His name is Dr. Shashikant, and this was after a long OT. He had put in an ICD. It was a long OT. We did around 99 cases in a month in trauma, and this was him after a long hectic OR day, sitting down anywhere where you get some rest. So yes, surgical residency is going to be tough physically, mentally, and emotionally, but you would finally realize after 3 years that you have probably grown fastest in these 3 years than in any other phase of your life. Even those 2x heights at 1 year of age, that neonate into 2x, whatever we learned about, this is like a transformation. I say this is like a metamorphosis, because you learn things which you never imagined you would be learning, and you test your patience, you test your resilience, you test your strength, and you kind of challenge yourself, and you kind of challenge in how you see yourself. There might be qualities in you which you never realized, which you never thought you had, and in the end of 3 years you would realize that, oh, okay, this is me, I didn't know. So it kind of shapes you into a surgeon with judgment, skill, and resilience, is what I would say. And this is the truth. Yes, it is tough. It is physically, mentally, and emotionally tough. And I congratulate all of you who all are joining this residency in spite of all the odds. Because you know this thing that only three people out of the top 100 or two people probably took up surgery. But you know, those two people who took up surgery was like entirely out of their passion and love for the stream. And once you have the passion and love for this field, there's nothing else which can give you more happiness and more joy, and I can vouch for it. So, this is the most important slide of this next 40-45 minute talk. And this is kind of the roadmap. So, you have your 3 years: first year, second year, and third year. So, I call the first year as the foundation year, the second year is the skill year, and the third year is the speed and the judgment. Also, I would want to say right over here that surgery has got three pillars: one is the pre-op, one is the intra-op, and the second is the post-op. Pre-op and post-op are the two pillars which you're going to learn in your residency. Intra-op is the pillar which you're going to learn throughout your surgical career, maybe till you are on your deathbed. We keep on learning surgical skills, we keep on refining it. In spite of the 3 years of residency, a lot of hands on, I still would say I'm not confident in almost all the major surgeries, and I'm very sure I would not be confident even after say 15 years, because every time you do a surgery, you learn something new, and it's you on how you judge your confidence levels. The first year is the foundation year, which kind of builds everything together. So you kind of learn the systems, I would say. You learn the OPD, you learn the OR, you learn the ICU, you learn what belongs to which place. You also learn to be reliable, because when you are a resident in your first year of residency, as a first year resident, you are the main kind of link to the patient and to the seniors and the doctors and the consultants who are going to operate. So you have to be reliable in the sense, if you pass on a message to your senior should trust you on it. And if you send a wrong judgment, or maybe a wrong message across, then probably the next day morning you would be bashed right, left, and center. And it is thus very, very important on how you learn to document and also to communicate, and we'll talk on this a little bit more in the subsequent slides. But it is the first year where you learn how to build stamina. Many of you might have had hectic internships, many of you might not have had hectic internships. By hectic internships, I mean something like a 48-hour shift and no sleep. This is something which would be very, very common in your surgical residency. You might have a double admission day. Maybe suppose you had an admission day on Saturday, which ended up, say, including a Sunday, and then again Monday you had an admission day, or maybe Sunday and Monday you had an admission day. So that's 48 hours straight, no sleep, because those 48 hours you at the first year would be there in your ward receiving all the patients who would be admitted from either ER or the OPD. It would be your responsibility to receive the patient, and now keep noting what your responsibilities would be as a first year. So I want all of you to imagine yourself as a first year waiting in the ward at say around 1 p.m. of your admission day, because the first 4 5 hours of the day would go into seeing patients in the OPD, receiving some patients in the ER, and you would be seeing and managing the patients who were already admitted in the ward the previous day or who were the backlogs. Around 1 to 2, you would start receiving admissions from the OPD. Now, these would be the set of patients who might be scheduled for an elective OT the next 2 or 3 days. So, suppose you are in the Unit 1. Unit 1 would usually have a Monday OPD or an ER. As an intern, you would know about it. And suppose on Wednesday and Thursday, you have your OR days. So, you would be receiving the patients, and it would be your responsibility to take their histories and also prepare all of those patients for the ORs which are scheduled on Wednesday and Thursday. On the same time, if you are having another co-JR, he would be receiving the patients in the ER, or he or she might be in the ER, who would be taking in the admissions of the patients who would be scheduled for the ER emergency OR on that particular day or maybe the next day. So these would be the two major tasks which you would be doing, and this would require a lot of documentation and communication. So you need to be very, very good with your communication skills, with your WhatsApp typing messages skills, with taking good pictures of the patients, recording all the documents, all the history, building a stamina. And here it comes on how to manage interns. So someone asked me, how do you learn how to manage your interns? See, interns are your biggest assets. They are your right hand, left hand. It's kind of the multiple hands you have, right? So you should know which intern is having what kind of capabilities. There might be some intern who would be street smart. There might be some intern who would have contacts across various departments. There might be some intern who would be very good with the talking skills with the patient. So you should be aware as to which intern to be relying on what skills. Maybe you have to counsel a patient for a surgery. Maybe you have to document and take history of a patient. Maybe you have to escort a patient to the ER or maybe to the CT scan room. And maybe you would have to take your intern might be having to take kind of the slips, which we call as the reference slips from your department to another department. And it is then it relies on those interns, and as well as you yourself, how much you build your contacts across all the various departments and how you can go and get those works done extremely quickly. So there would be instances in your first year day when you would be asked to get a CT scan of a patient within an hour. And you would think, how is it humanly possible? You would go to your radiologist friend, maybe a senior, and you would beg, do everything possible just to get a CT, maybe lie that the patient is dying, this patient needs a CT, sir, else the patient would die, please do the CT. Or maybe there's a patient who was planned for a laparoscopic cholecystectomy on Wednesday, and on Tuesday evening, just before the OR, you realize the patient has lost his ultrasound whole abdomen report. And your senior says that, I don't know how, but you have to get a USG done. It is then your contacts play a great role. It is then your interns play a great role where you have to ask your intern that please run and get this ultrasound done from any of the radiologist resident who's there in the ER duty. Just ask him to document the size of the gallbladder, the number of stones, is there any CBD stone or not, some basics things, right? So that saves you, and you kind of build in more contacts and communications. So one small trick I would like to tell you right here is whenever you go to any other department in your first year, make sure you take their contacts. It might be a second year resident, a third year resident, an SR, and be very polite. Be as polite as you can. You might have to fake politeness, but you have to be polite. That is the reality. You have to be very, very soft spoken. Sir, please, ma'am, please, please, please kar do, please kar do. At the end, this really works, and no matter whether you're in a central institute or a state institute, you have to do this. There's no other way, and this works. A please will take you miles during your residency. It is then you come to your second year when you learn your skills, where you learn a little bit of hands. I would say not a little bit, because in first year it again depends on whether you're doing it from a central institute or a state institute. In my central institute, I would have my junior just after the first 6 months. So I would be then sent to my minor OR to do stuff like a hydrocele, an eversion of sac, a small swelling, some basic biopsies, and then maybe in the ER I would get to do some hernioplasties, herniotomies, basic stuff. Maybe assist in the laparoscopic cholecystectomy, show the camera, assist in the ER OTs. But in the second years is when you kind of get more reliance. Maybe you would learn how to close the abdomen, make a stoma. In the elective OTs you would get to show the camera, or maybe you would get to do a little bit of calyx dissection. If not calyx dissection, maybe the gallbladder uh, bed dissection. So these are some skills which would vary from college to college and place to place. But in your second year you would be very thorough on how to manage your with confidence. So basically, in first year, you would be knowing which ER patients to take in, how to manage their pre-op and post-op, which you would be learning in your first year from your seniors. But in the second year, you would be assisting major cases. And if you're in a central institute or in an institute where you have a lot of super specialty exposure, so you would get to also go to the super specialties. And in the super specialties, you can definitely take up leaves and start going to conferences and start doing your research work. So again, I must highlight here that there is no kind of scope of doing academics per se in your first and second year. So I would not want you to start hunting for a super specialty entrance examination, take up a coaching, and start working on it, because the first and second years build up your foundation, and the maximum you would learn in your in your OPD, in your OR, and that would be much more and much beyond what you would learn from your books and from your coaching materials, right? So it is a very different thing. It is not like you were in your NEET PG preparation, where from the second year you would take up a coaching institute and you would start to read the videos and stuff. Yes, you can do them, but that would come at a cost of your learning hands on, or your learning from your eyes and your hands, right? So you should be thorough by your second year in doing basic OTs, the dressings, the debridement, managing the yourself, managing the pre-op, the post-op, and definitely I would also come to where your academics would come in the first and second year. And again, if you are in an academic institute, maybe a central institute, you would be in your first year presenting short cases. In a second year, you would be presenting journals. So they would be a part of your residency program, but they would not form the major chunk of it. The major chunk would definitely be going to the patients, talking to them, learning from them. And in the third year is when you develop your speed and judgment. You start taking independent decision making. You are the boss of your EROT. You would be reporting to your consultant. You would be the registrar. You would be managing your juniors. What a second year would get to do, what a first year would get to do. You would be teaching your second year how to make a stoma, because by the end of second year, maybe by the start of the third year, you would be thorough with your EROTs. So it is then you would start focusing more on the academics, the exams, maybe attend a few conferences, more conferences, and kind of build your career path. Decide what is your liking. Do you want to do neurosurgery or a gastrosurgery or a cardiothoracic vascular surgery, etc. So I hope this is a brief picture of the year-wise roadmap, first year, second year, and third year. And I hope this is a little bit clear to you all. If you have any questions regarding this, please feel free to type it on the chat box and I'll go ahead. Right. So, I would now focus on the first 90 days survival guide, because this 3 months of a residency, the first 3 months of a residency is kind of the most crucial, because you would be going at a new place, in a new department. You would feel alone at times. You would not know whom to share your, daily troubles with. You would be finding it difficult to talk to your parents, to your loved ones, to your girlfriend, to your boyfriend. It is difficult. There's no fancy things over here. I would not sugarcoat it. It is difficult. I hope everyone is able to see this picture. So I joined my residency in September, and by the end of December, I would spend the entire week in the ward, because we had a good ward doctor's room. So I would sleep there. It was like 2 degrees, 3 degrees winter time, end of December. So I remember one day I went. So I would basically go to my ward on Monday morning, and I chose basically to stay back in the wards. My other co-JR would go back to her room on say Tuesday, Wednesdays, and Thursdays, etc. But I chose to stay in the ward room, because there was a good place to, I won't say take a shower, but use the washroom, use the loo, brush, eat. Everything was fine. So I went back to my room on Sunday night after 7 days, and what I saw was that my entire room was black. First, I thought maybe my electricity had gone, so I switched on the flashlight and I saw everything was still black. It is then I called in my seniors and I realized that my entire room was burned. My room had a fire door, so no one came to know about it, but probably there was a short circuit. And there's a small picture which you can see. Uh, the shadows, those white spots are of the books which were kept, which again were burned, and it was all black. It was very painful, but this is how residency is. I chose not to go to my room. It was not that I could not have gone to my room, but I thought probably by the time I would go to my room and come back, it would be better to sleep in the ward room. So, yes, you have to therefore know your ward inside out, the beds, the supplies, the dressings, the forms, whom to call, even the Masi, the Aya Didis, the people who would deliver food, everyone, each and everyone in the ward should be your friend, from the nursing staff to the Group D staff, because they would help you in days when you would be the most miserable, when you would be missing out your breakfast, your lunch, your dinner. It would be them who would get you food. They would come to you and say, नहीं नहीं भैया आप प्लीज, सर आप प्लीज बैठ जाओ, आप प्लीज खा लो, अरे हो जाएगा पेशेंट का, हो जाएगा, आप खा लो थोड़ी देर, एंड देन वुड बी नहीं नहीं प्लीज प्लीज मैं कर लूंगा काम, मैं बाद में खा लूंगा, देन नहीं नहीं आप खाओ पहले, आप खाओ तब काम करना. You would realize it later how beneficial those moments were. Those were the golden moments. Those will be the golden moments of a residency, where your nursing staff, where your ward didis, your aya didis, your group D staff, people who would be sweepers in your ward rooms, would be basically the people who would be taking the most care of you. So you have to kind of make a good contact with everyone in your ward. The second is learn to do a proper post-op assessment. Again, this is not something which I can teach you in this presentation, but how to take vitals, urine outputs, drain outputs, wound, how to escalate triggers. If you see the patient is not doing good, whom to inform next, who's the second on call, who's the third on call. All these things are very important. How to make a good and clean discharge, writing all the diagnosis properly, the pictures, the meds, the red flags, the follow up. Because, see, when you put in your efforts as a first year in your proper documentation, post op assessment, writing a good discharge, it is then you earn the trust of your seniors. And in surgery, OTs are earned. You remember that bone will add? You don't buy a bone will, you earn it. It's the same which applies to surgical residency. You don't buy your OR, you earn your OR. And your senior is going to trust you only when you are able to manage a proper post-op ward and a proper pre-op ward. You should know the common drugs, fluids, and antibiotics. And this is where I come to the question where most of you are afraid that, sir, I don't know enough. Even I didn't know enough. No one knows enough. But when once you start working in the ward, you would realize that, okay, I gave a patient a PCM infusion and this patient had shivers. So the nursing off told me that, sir, let's stop this PCM. Let's give her some, say, any anti-allergic. It can be something like Allegra, it can be something, anything which the ward has at that particular point of time. Or maybe run, say, 500 ml of NS. Or maybe at times patient might be having some chills just after you give NS. Or maybe you would take a sample from the central line through which the nursing officer had put in potassium infusion, and the potassium comes out to be 7 the next day morning, and you are bashed by your seniors saying that you didn't notice that the patient has a potassium of 7, and it is then your intellect and your presence of mind comes into play that, no no sir, this patient had potassium infusion going on, and by mistake the nursing officer or you took the sample from that same cannula or the channel, and so the potassium came up. So these small little things no one is going to teach you. This is what you would learn while working in your ward. And it does not matter if you have worked till now or not. If you have worked in your internship, if you know how to put a cannula, if you know how to put a rice tube, if you know, yes, you would save some time. If you don't know, your nursing officers, your seniors, they will teach you, because they cannot run away without teaching. If they don't teach you, probably they will again have to work in the ward. So they will make sure that they teach you these small things properly before they leave the ward on you. So don't worry about them. So you should also be kind of having some daily habits like pre-round every patient. What I mean by this is, because see, most of the times what happens is the first year is very busy with the workload, and you kind of miss out on the patients. You don't take a proper history, and then your second year, your third year comes, he is again relying on you for the history, and even they don't take a proper history, and in the OR something wrong happens, and then it comes back to the third year, and the third year would ask the second year, and the second year would ask you, and you would realize ki, oh freak, I didn't take the history that the patient is on aspirin, and the patient was bleeding in the on the OR table. So these are big blunders. So if you don't pre-round every patient properly, if you don't ask the patient what drugs are you on, what are your comorbidities, because you are the first hand source of any information as a first year resident. And if you fumble at these points, then there is no saving, because then basically no one is going to say anything to you if it's a non-toxic department. If it's a toxic department, definitely you would be hurled upon, you would be abused upon. But then if you don't have a toxic department, the only thing which is going to happen is you would lose on your OR chances. This is the biggest punishment which a aspiring surgeon can have. So you have to be very thorough with this. Also, always remember, you are not responsible for anything if you update your senior. So this is one hack which every first year should know. If you think there is something wrong with the patient, it can be anything. It might not be even wrong, but you think it's wrong. Just give a phone call to your senior and just update your senior that, sir, this patient is having tachypnea. So this patient is post-op. This patient is having tachypnea. You might not know why that patient is having tachypnea. Maybe the second year would come in and ask the patient that आपको बहुत दर्द हो रहा है क्या? And then the patient would say, yes, sir, I'm having a lot of pain. And then you would realize that maybe the patient is having a lot of pain. So the patient is having tachypnea. So let's give him a little bit more of analgesic and the tachypnea would subside. Or maybe the patient is having a metabolic acidosis. So definitely you would know how to look at the APG, which again you will learn. And then you fail to realize that, okay, the patient is hypovolemic, or the patient is probably losing blood or bleeding somewhere from the intraop, and you don't inform your senior and the patient collapses in the night. What could have been done better is you informing your senior that, sir, the patient ABG has come in. It shows an acidosis. Sir, I'm not sure what is wrong with the patient. Please come and examine. The second year says, nah, nah, main nahi aa raha. I'm not coming. You manage yourself. No worries. You inform your third year. Just drop that message in the group. There would be a group with your SRs and your seniors. Someone sane would see that message and will tell you, please look at the drain. Please examine the abdomen. It might happen that the patient is bleeding inside and you see a tense abdomen. So you know there is a hemoperitoneum. You might see blood in the drain. So you know that, okay, this patient is not doing well. So let's escalate it further. So it's very important that you update your seniors early and you document everything clearly. Anything goes wrong, document on the daily charts or on your that notes which you write every day. Anything, the patient had chills, the patient had was running fever, you sent culture sensitivity, just document it. What would happen is tomorrow, suppose the senior comes to you and says that, Shubra, did you send your blood CS for the patient? And you kind of forgot that, sir, I don't remember. Sir, wait a second, I had documented it. And you see that you have documented that you have sent a blood CS. So you are saved. Now, suppose you sent, you don't remember, and you have not documented, then you would be screwed. It's as simple as that. So documentation is going to help you immensely. So this would be my first 90-day survival guide. Again, some essential skills: IV cannulas, catheters, rail tube insertions, basic suturing, drain care and removal, wound dressing basics, ABG sampling. All of these you would might have learned in your internship. You might not have. You would be taught by these amazing people who would be nursing officers in your ward. So, or nursing officers, or your immediate seniors, or even some very good intern who would be working there, who knows how to put IV cannula, who knows how to put a RT. So, at the end of maybe 1 or 2 months of a residency, you would have put in 100 IV cannulas, Riles tubes, catheters. You would have learned how to do the basic suturing. So, you should not worry right now that, sir, I don't know how to do a basic suturing. Even if you don't know, your senior will teach you. There's no other way that, it cannot happen that senior would not teach you, because if he will not teach you, then probably he will not learn it better. And if he does not teach you, he would never be able to kind of shift the duties to you. If he keeps on suturing the patients, then probably he is going to spend more time in the OR, and probably he is missing out on that third year and second year of academics time. So he will teach you eventually. So the only mindset and the survival hack is that you have to get used to long hours, unpredictable routines. Maybe right now you would get a call from, if you are a resident and you get a call from your senior, uh, Ram, please go and see this patient in the ER. He's the patient of the head of the department. You have to go and examine him. And you are like, sir, this is not even my ER. Why should I go? It does not happen like that. This is surgical residency is all about. You have to be prepared for such unpredictable routines. You have to tell your parents from now that you would be having such days, your loved ones, and you have to eat and hydrate whenever possible. There is not going to be a specific time कि बॉस 9 बजे ब्रेकफास्ट का टाइम है, 2 बजे लंच का टाइम है, 9 बजे, ये नहीं होने वाला. दिस इज नेवर गोइंग टू हैपन. Please forget that there would be a specific lunch, breakfast, and dinner time. Whenever you get time from your busy routine, grab your lunch, grab your dinner, grab your breakfast. How are you going to do it? That you have to figure out in the first 7 days. Get contacts of all the messes who deliver food to your hospital. Get contacts of all the people uh, who order food, Zomato, Swiggy, anything and everything. You should know if at 2 a.m. in the night you get free from an OR which started at 6 p.m. and you have not had dinner and the mess is off, mess is closed, you should know where to order the dinner from. It should not happen that you're sleeping empty stomach, because again the next morning you're going to skip your breakfast, and then the loop goes on, and then you would end up losing 10-15 kilos, and then you would end up having tuberculosis. This is the harsh reality of residency which no one talks about. So please, please and please eat and hydrate whenever possible. Don't hide problems. If you see a problem, maybe you have created that problem, accept it and escalate it. Maybe you have put a Riles tube and they see you bleeding, and you kind of just pack the nose and do something and just get away. It is not going to help you. The patient might aspirate and die. You have put, suppose, a central line and it has gone into the subclavian artery. You should know that this is wrong. You have to inform your senior. It is okay to make mistakes. You are going to make mistakes in a residency, and the moment you realize that it is okay to make mistakes, as long as you accept it and you tell your seniors that, sir, ma'am, I have made this mistake, I'm sorry, please tell me how to rectify it. If you start hiding your mistakes, if you hide your problems, if you hide away from them, you're never going to learn anything in a 3 years. Be polite with the nurses and staff. Academics, try to read 10 to 15 minutes on a cases daily. Suppose you have a patient with kind of a new presentation, maybe something like an autoimmune pancreatitis, maybe something like an achalasia cardia, maybe something like a periampullary carcinoma, and you don't know about a lot about Whipple's procedure. Chat GPT, Gemini, Perplexity, n number of things. Yeah, just type whatever it comes in a shorthand. Just read about it 10 minutes. You don't need to carry books. Back 10, 15 years back, people would carry Washington's manual, people would carry some ICU manuals. Don't have to do that. You just have to ask a chat GPT, you just have to ask Google, Gemini, and read whatever is there on that particular disease, on that particular patient. Even if you're not able to understand anything, just read 10, 15 minutes. Read while you're shifting the patient to the CT scan. Read while you're shifting the patient for the ultrasound. Just read. This is the time where you're going to read in your first and second year. More in your second year, very less in your first year, but try to read. Even if you can read about one disease per week or maybe two diseases per week, at the end of first year, and surgery does not have a lot of diseases. There would be some common set of diseases like gallstone disease, peptic ulcerations, peptic perforations, obstructions, sigmoid volvulus, some basic funda diseases, and then there would be some high-fi disease once in a moonlight, maybe something like a GRD, maybe someone who is planned for a fundoplication, maybe someone who is planned for a distal pancreatectomy, maybe someone with a chronic pancreatitis. But someone with an acute pancreatitis would come almost every day in your year. So you should be aware about acute pancreatitis, A to Z, everything in your first year. And how is that possible? Reading in between shifting patients, in between ward work, while sitting in the OR, or before sleeping, anytime, whenever it's possible, 5 minutes, just read. Again, focus on being reliable, not fast. It does not matter if you can see 100 patients. It does not matter if you can do a 30 dressings. But if you can do those 10 proper dressings, you would go a long way. Because in that case, you are also learning, the patient is also getting benefited. बट इफ यू जस्ट डू योर वर्क जस्ट फॉर द सेक ऑफ डूइंग कि आज 30 पेशेंट्स के ड्रेसिंग करना है किसी तरह से, बस रैप कर दो, दैट इज नॉट गोइंग टू हेल्प. Sorry if I'm using a little bit of Hindi words here and there, but I hope people are able to understand. What I mean to say is, you cannot run away from your duties. You should know, you should be street smart how to divide your duties among the various co-JRs, how to allot the work to some interns, some nursing staff. It might happen that you have to put 10 cannulas. There might be a nursing staff who is free from his duties. You might just ask him, sir, please, or maybe, brother or officer, please, can you put 5 cannulas? I'm in a lot of rush. Can you take 10 samples? I'm not able to manage. It is going to come very handy. You might just, you would create your hacks. Maybe you have to do 10 dressings, and every day you are seeing that, okay, these are the 5 patients whose dressing I'm doing daily. What you can do is you can teach their family ones that before I come for the dressing, make sure the patient is ready, make sure the patient has taken a bath, make sure you have removed the dressings yourself, because removing dressing does not take a lot of skills. And when you are doing the dressing, maybe you can teach the family person that, sir, when I'm doing the dressing, just put some betadine, just put some alcohol over here. That is how you learn and adapt. This is very, very important. And this was the major part of the surviving residency first 90 days. I think we would go further ahead. I would just have some water, and I would ask anyone, if you have any queries till now, please go ahead, because next 20 minutes is going to be very rapid. This was the main part, and rest, I think there are 10-15 more slides, but there'll be more on things much beyond the first year. Yeah. So we come to the fundamentals of ward work, right? So we kind of spoke about the daily rounds, we how to do them properly. Uh, Basically, it depends on the pre-round, and then it again depends on whether you are the person who's going to update your seniors in the ward rounds. But you should know, and you would get trained after a particular point on how to say that, okay, sir, this is Ramesh Kumar, he's 26-year male, he is presenting to us with a pain abdomen for the last 2 days. He's also running fever, he's having mild jaundice, there's a history of choledocholithiasis. So the patient is vitally stable, the BP is this much, the pulse rate is this much. I've sent in the investigations, the CBC has come in, the TLC is high, the bilirubin is high. So I'm suspecting the patient to be in cholangitis. The patient is currently stable. I've started him on medications. I've started him on broad spectrum IV antibiotics. So this is the kind of way you would want to give a daily round update, and I have a SOAP format on how to even take down notes, and I share it on the group. Note making and history taking, again, what must be documented. I'll be sharing a short document on what is the SOAP format: subjective, objective, assessment, and pathology. So it again talk about it. Communication with seniors and nurses, very, very important. You have to learn them. Drain management, catheter, wound care, we have talked about it, and how to escalate issues early, again, through WhatsApp, text, etc. So this is a picture of a sigmoid volvulus. I hope people are able to see this. I think this was the OR which I did in my fag end of the first year. And yes, in my first year, I was doing emergency laparotomies, which is not the common consensus which people think that in central institutes people get hands. But yes, I was able to do some laparotomies in my first year. You always follow the ABCDE approach: the simple airway, breathing, circulation, disability, and extremities management, etc. You recognize sick patients immediately. You kind of also learn how to manage the trauma cases, what are the basic investigations, when to call your seniors, and again, don't delay decisions. Again, these things are not what I can teach you through this PDF or this session. These things are what you would learn in your ER, mostly from your second year seniors. Again, the ICU basics, very important. The ventilator basics, uh, basics of ventilators, not hi-fi stuff. I learned ventilators from Sabiston. There's a small chapter on ventilators. I learned it from the Washington manual, because we had an ICU posting for a month. You would be having ICUs in some of the colleges which would be handled by you as surgery residents. There might be ICUs which would be managed by the anesthesia residents. So you have to kind of have a good contact with them, learn on how to start NORAD, when you start vasopressin, when you start adrenaline, what are some basic ABG interpretations. I would be more than happy to take a class on these if you guys want me to, but definitely out of the scope for this time. But these are things which I would want you to learn. Basic ventilators, just basics, what is tidal volume, what are the various modes of ventilator, what you learned for your NEET PG prep, what are the basic vasopressors, how much is the dose, what are the side effects, just basic ABG again, which was very, very important for the INI set in PG exam as well as NEET PG. Basic metabolic acidosis, very useful for surgeons. Mostly patients would be hypovolemic. You should know what is the urine output for the last 3 hours, what is the fluid balance, how much fluid to give, the ATLS shock protocols, the hypovolemia, grade 1, grade 2, grade 3, grade 4, and some patient post-op care and essentials. The patient is running hypothermia, how to manage warmers, etc. And so this question is very pertinent. Is surgery all about hands? No, hands come later. Your brain comes first, is what I say. I said that surgery is not just about intra-op, it's about pre-op, intra-op, and post-op. This is a picture of me when I did my first EDH evacuation. This is in my second year in my neurosurgery rotation. Again, not something which I begged for. It was something which I earned after working hard for a month in the neurosurgery ward. You should know what is the anatomy of a patient, what is the anatomy of a particular pathology, how do you plan for the OT, what are the complications you're anticipating. Then comes a judgment of those competitions and also recognizing complications early. Because if you can learn these five parts, the anatomy, planning of the surgery, anticipating the problems, judging the problems or having a good judgment, okay, I should do this, I should do that, and recognizing the complications early. For example, you should be able to identify a post-op leak. The patient has underwent an EL with a resection and anastomosis, and patient on post-op day 2, day 3, at the night at around 2 p.m., 3 a.m., 2 a.m., having a lot of pain. The abdomen is tense, the urine output is very low, patient is tachycardic, patient is running fever, and you are the only person in the ward and you are thinking, oh man, what went wrong? You examine the patient, you see that the patient is having a little bit of peritonitis, you see the drain, you see that the drain is having feculent material, so you know that somehow maybe the anastomosis has leaked. So this is just identifying a post-op complication. You should know how to manage an acute abdomen. The first step of a perforation peritonitis is not to shift the patient to the OR and to do an expiratory laparotomy and a Graham's patch repair. The first step is to examine the patient, examine the abdomen, see if the patient is stable or not, resuscitate him. ABCD protocol, very, very important. Get an X-ray done only if the patient is stable. Then prepare the patient for the operation. Is the patient having low hemoglobin? Arrange for bloods. Is the patient having low platelet counts? Is the patient having a deranged INR? Arrange for FFP. Then you ship the patient to the OR, and then your seniors operate them. And then your seniors know that, okay, I was able to save this patient because the pre-op was done so well. You resuscitated the patient properly. You gave enough RL. You resuscitated the patient based on the APG. There was acidosis. You gave him proper fluids. There was a good urine output in the OR. Your senior did a good Graham's patch repair. The patient was able to be discharged on fifth day. The patient went home. The patient comes back. It is you who the patient is going to thank. It is you who the patient is going to give sweets, the JR1 of the ward, in front of all the consultants of the ward, because you are the patient who kind of saved their life, is what the patient would feel. And yes, it is you who saved his life. It is not the surgery which saved the patient life. It is your proper pre-op and the post-op judgment and management which saved the patient life. So I again and again emphasize, surgery is not just about hands-on. You would get hands in your second and third year eventually. You would learn how to do a Graham's patch, and you would get bored of doing a Graham's patch. That in your third year you would teach your interns how to do a Graham's patch. But hands come later, your brain comes first. So train your brain properly. You should be able to know the anatomy, plan, anticipate, judge, and again recognize complications early. So I hope this answers the questions. So you might ask me, sir, what do I do to get the OT hands right? It's very important. If I am a senior and I've got 3 junior residents under me, so whom am I going to give the first hands? Whom am I going to give the first herniatomy, uh, hernioplasty opportunity? I would give the first opportunity to a JR who arrives early to the OR, who reads about the case one night before. It should not happen that I am doing a thyroidectomy in my third year and I ask you as a JR1 that just tell me about the RLN and the nerve injuries, and you are clueless because you have forgotten about the RLN and the nerve injuries which you read so well, which you might be knowing it right now so well, but you would forget it after 6 months because you would blame it on your hectic residency. कि क्या सर आप तो सोने भी नहीं देते हो, you don't allow me to eat properly, you don't allow me to sleep properly, how do you expect me to know the RLN? It is when I say you might not know everything about the OR, but maybe a little bit on the anatomy, a little bit on what is the incision, how is it done, what are the post-op complications, just some basic anatomy, some basic steps, and there are some great books. Again, if you don't have the access to a book, ChatGPT, great. Gemini, great. Just read about it. You know, help help your seniors in proper patient positioning, ports, what are the instrument setups, what are the sutures which would be needed. In my department, it is the first year whose responsibility is to order sutures, and I make sure that my first years get to the OR and see a case, and I teach them, okay, these are the sutures which are required for this and this step, so that you're not just randomly ordering any suture. You are able to imagine the surgery being happening. That okay, fine, I'm going to give an incision. I'm going to do an RA, so I would need say a PDS 30 or a Vicryl. All of those sutures which I've read would come very handy. Okay, then I'm going to close the abdomen. Again, I would need something like a loop PDS or a PDS 20. Again, okay, I'm going to put a drain. I need a silk to fix the drain. Okay, there was, I have cut end of the rectum and I need to keep it, but mark it with a Prolene suture. Okay, there was a vascular injury. I need to use Prolene to repair the vascular injury. There was a mesh. I need to put tackers. Okay, there was a hernia case. I need to order mesh. The mesh size should be 10 into 7.5 or 15 into 7 or 15 into 10. All of these small things you would learn eventually, but if you're arrogant, you would never learn. So again, be reliable. Seniors give you hands if you're reliable. If you help a little bit in the OR, eventually the senior would be like ki, acha aao, come today, you give the incision. Okay, today come, you dissect the cord. Okay, you come today, you put the mesh, you fix the medial side of the mesh. Okay, do one thing, you close the abdomen today. So those small things, eventually A plus B plus C plus D plus E, like this you would learn the entire thing. Okay, so you would not learn the entire summation in one day, but the bits and parts, and that one particular day when you would get the opportunity to do it fully, it is then you need to remember and reconcile everything which you have learned in in the last 1 year, 1.5 years, and put it all together in a very beautiful dish. So you might have learned how to put an incision in some other OR, how to put the mesh in some other OR, maybe how to close the abdomen in some other OR. But today, when it is your opportunity to do, don't be arrogant. You have earned your surgery. You will earn them eventually, and I promise, and I really promise you that you will earn your surgeries. It is then you need to show that yes, I am a good surgeon. I am a safe surgeon. I do not randomly go in the OR and do anything, and I am able to do a proper OR. So again, the OT etiquettes, respect the anesthesia and nursing teams, very, very important. You cannot go and say to the anesthesia resident any random stuff, because they would be, if they're not there, you would not be able to operate. So be very kind and respectful to them. Be very kind and respectful to your nursing teams in the OR. They know much, much more than you as a first year. They would teach you basic skills. When the second year would ask you that, close kar loge, and you would be looking at your nursing staff and be like, कर लूंगा. And then your nursing staff would be like कि हाँ हाँ, you say yes, I'll make you close. And then you would say your senior that, sir, I'd be able to close. Okay. And then your senior would be, okay, you do. Then your nursing staff would teach you how to close. Your senior would be there standing because he has also learned it like that. But if you say no, sir, I won't be able to close, damn, if you are a surgeon, you should have that courage to say yes. If you're given an opportunity, grab it. You might not know how to do it. Just say that, yes, sir, I'll do it. Just make sure that your senior is there. Obviously, he'll be there watching you, because he'll not leave you like that, because he also knows that you'll be doing it for the first time. But yes, so keep calm. Don't talk unnecessarily in the OR. Watch, learn, and anticipate. Very important. If your eyes do not know, if your mind does not know about the thing, your eyes will never be able to catch them. So you have to keep watching, keep learning. You watch 100 surgeries, you assess 20, and you do one, is what I say always. You need to know your instruments. And this is me doing my first laparoscopic splenic deroofing of a cyst in my first year of residency. Again, something very remote to other people. But again, I didn't do the full OT, but I was there throughout the OT. So in the end, this is my unit head. He asked me that, okay, you can play with the harmonics. So on my right hand is a harmonic scalpel, and I did a deroofing. So these small opportunities come your way once you keep doing. So you have to be a good junior. You have to avoid some mistakes. You do not disappear after rounds. It should not happen that rounds ho gaya, bhai mera kaam khatam, I'm going home. This should never happen, because after the rounds you'll be getting some works to do, and if you miss out on those works, you're gone. Okay, so you have to be there in the wards after round, because you as your first year would be the person who will be doing the majority of the work. You have to communicate problems early. If you don't communicate problems early, if something goes wrong, if the patient dies, you would be screwed. Why didn't you inform me before? You knew the urine output was less. Why didn't you do this? And then you would say that your senior is being toxic. So these small points you have to make sure that these mistakes do not happen. Yes, you will make mistakes, maybe try to minimize them. You don't argue with your seniors. The seniors is going to give you hands at the end of the day. Yes, I am not saying that you should blatantly listen to all the abuses or anything. If there's something going wrong, you should be having that strength and courage to fight for yourself, to report your senior. But again, don't argue blatantly for any reason. If your senior is saying that okay, this is how it should be done, maybe he's wrong, but you have to be polite. Sir, I think maybe this is the way it should be done, I read it. Or maybe you just keep quiet, read your own self. Maybe you were wrong, maybe he's wrong. He would eventually realize it. You are there to be a good surgeon, not to make others good surgeons. Okay, you have to be yourself a good surgeon. So if your senior is doing a mistake, if your senior is not able to fix a mesh properly, and you have read the night before in a good book that this is how it should be fixed, maybe okay, this is not the way it should be done. Even that is a learning. Not reading cases a big mistake. Try to read your cases a little bit. Poor documentation. You see, you make a poor documentation, your intern is going to make a poor discharge. That discharge would end up with a unit head when the patient comes to the OPD. The unit head would call your SR, the SR would call your third year, the third year would call your second year would check who has made the discharge, and the intern will not be the screwed. You would be screwed because you made the wrong documentation the first go. Again, don't stay up late unnecessarily. Don't try to show off that okay, I'm a surgery resident so I can be awake the entire night. It is not going to help. Catch sleep whenever possible. Sleep at any point, wherever you find space, just sleep. Try to maintain your mental health. Do not ignore it. There might be very tough times. You would not be able to sleep, will not be able to talk to your loved ones. You might be feeling very depressed. There might be thoughts that why did you take up general surgery? But believe me, at the end of first year, the moment you enter your second year, third year, at the end of 3 years, you'll be like, "Ki, that made me a better surgeon." Again, I'm not justifying toxicity or anything, but this is how it is. Surgery is hard. It is not just about seeing a patient, prescribing some medications and discharging him. You have to see the patient pre-op, post-op, intra-op, and again when the patient comes for follow-up, you have to do the dressings and everything. Because imagine you are putting a patient to sleep by giving an anesthesia, and you didn't do a proper check. The patient was a chronic drug addict, and the anesthesia gave some drugs, and it kind of interfered with, suppose the patient was a cocaine abuser, didn't take the history, something went wrong and the patient did never came back, and you lost the patient. So you would blame yourself for the entirety of your residency that you didn't do it properly. So it's very important to do proper documentation, have a good photo phone with a good photograph skills. This would take you long ways. You should know how to take good specimen pictures, good pictures of the complications of the patients who present to the OPD, etc. So these are some very, very simple things, but yes. So these are the residency toolkit. Must have outcomes. Some good scrubs. Kanya is very good. So you can buy those scrubs. I still wear those scrubs when I am right now in my room. They're very comfortable. Get some good comfortable shoes. Skechers is tried and tested. You can buy in Crocs for your OT slippers, but Crocs you cannot wear for the whole day. It's always better you wear some good comfortable Skechers shoes. Have a good power bank because your phone is going to be your best friend. A good stethoscope, a decent stethoscope. I'm not asking you to buy a Littman, but you would need a stethoscope to check for the pulse, the BP, then your abdominal sounds, etc. It's very important, and also count the number of peristalsis. A small notebook for the rounds will take you a long way. Some decent protein bars and electrolytes. I think most of them are available on the Blinkit, etc. now. Just have a side bag and keep extra of everything. You find some bandages, keep it. Syringes, keep it. Sutures, keep it. Your that one bag which you carry should be that one complete bag where you can pull off a laparotomy at any point of time. You should have all the good sutures, okay, all the important essential tools, a rice tube, a Foley's catheter, because suppose you have to do something at this point of time, then you keep running to get the stuff, so you basically waste your own time. So if you have extra of everything, it's always good. A good phone with a good camera is again something which is very important. I would want to take another session on research and publications because there's a lot to cover on that as well. But yes, you can start simply like case reports, case series, posters, and I'll definitely take another session on this because it's impossible for me to cover everything in one place. But then definitely once you start with case reports, case series, you can go with the original studies, RCTs, thesis, etc., and use the AI tools. Some of the conferences again which you should attend in your second years and third year. Again, I will take another session on this, but just briefly summarizing, it would be your state conferences, ASICON, which is happening in Kolkata, IAGS conferences. I would share some links as well. There's an AWR conference community if you are interested in abdominal wall reconstruction. So this is basically the hernia society kind of thing of India, and I'm too much a fan of hernia. There's a MASICON, which is Associations of Minimal Access Surgeons of India, and some international conferences, which I'll talk about in the next slides. Why conferences are important? So someone told on Reddit that you can do conferences after you become a surgeon. That is not true. Yes, you can do, but when you do conferences in your residency, you kind of get a visibility, you network, you understand, you kind of get out of that small nest which you are living in. You have a lot of motivation, you also meet people, you build confidence, and you realize things which other people are doing which you're not doing. And these are some of the pictures of conferences which I attended. I think I've attended around 14 conferences in the 3 years, around three international conferences, and rest were national conferences. So this is Basicon, which was the state conference where we won a quiz. Then ASICON 2023, 2024, and now it's happening. And this is me trying to kind of also teach the senior JRs and residents, not teach, I would say, just demonstrate some of the skills which I learned in one of these workshops, which was held by Ethicon as a Future Leaders program. Which there's a picture on that as well, or I can take it later. What is the Ethicon's Future Leaders program, where you kind of learn? That is the first time I did a laparoscopic cholecystectomy on a pig. They have a center in Chennai. So it is there I learned how to do it, and I also learned how to fire a stapler. So these are small, small things which you learn, and then you can come and teach your other residents. So you kind of also learn how to build a strong CV, do presentations, publications. Uh, just yesterday, I came to know that two of like the publications which I was a part of, the studies, they have been accepted in Lancet. So this would be the third publication of mine which will be published in Lancet. Three publications in Lancet in the 3 years. I'm not trying to brag, but again, these publications were only possible because of the conferences which I went to, where I came to know that there are global research studies which you can be a part of on LinkedIn, on Instagram, by talking to people, etc. So you can do your workshops, certifications, some observerships. They obviously teach you leadership roles, and they also serves as your achievement. So I'll just share a few pictures. The first is of EAS, European Association of Endoscopic Surgery Congress. This was in Maastricht, Netherlands. This is where I went in my second year. My first solo trip, my first solo international trip. A dream which I had seen in my UG days to go to Netherlands for a conference. That time I couldn't go because of financial issues. This time I had enough money as a resident to finance it myself. The second is a picture from International Surgical Week in which was held in Malaysia. Usually, the International Surgical Week is held in Mexico and other places in Europe. This was the first time it was going to be held in Malaysia. It was a free visa. I had sent in a research paper, and they had accepted it for a plenary for a live presentation. So I did that as well. The third picture is from Japan. This is the Japan Surgical Society Congress, where I had presented my own thesis. So, when you present your thesis in a national, international level conference as a keynote, kind of, there are presentation, there's poster presentation, then there is plenary presentations, and there is video presentations. So, when you do a plenary presentation, or kind of a presentation where you actually stand and showcase your entire presentation to a crowd sitting in front of you, that really counts in your CV. So I got this opportunity again just because I kind of came to know about one conference and the other from the another conference which I went to. So you go to one state conference, you meet someone who tells you about another state conference. There you go, you get to know about an international conference. There you go, you get to know about second international conference, and it keeps on going like a loop. So this picture is very close to me. This first picture is me with Professor Noriyuki Inaki. He is a upper GI surgeon from Japan, and I had first met him in the EAES Congress in Netherlands. And at that time, I just happened to, just talk to him, tell him that, sir, I'm a resident from India and I'm very much interested in GI related works. Uh, I would be more than happy to come to Japan and learn under you. I had no idea that I would get an opportunity to go to Japan. And I just took contact. I saved his number. Uh, Going ahead, I was one of the podium winners for ASI ASICON TISA. and I had got the opportunity to go to Japan at the University of Tokyo Hepatobiliary and Liver Transplant. And over there, I remember Professor Inaki. I texted him on WhatsApp and I told him, "Sir, I'm coming to Japan. Would it be possible for you to allow me to do an observership for 7 days under you?" And he was more than happy to accept. So I went all the way from Tokyo up north to his place at Kanazawa, and there I got to operate Hinotori, which is the Japan robot. I did a proper 7 days training, hands-on training at their Da Vinci setup, and it was too good an experience. So this is how it comes. One conference leads to another conference, and the contacts which you make in one lead you to achieve other things as well. So these are the good parts of residency, but yes, the hard parts are always there: sleep deprivation, burnouts, humiliation. You might be humiliated in front of your patients by your seniors, and you would feel that how can a senior, humiliate me in front of a patient? Yes, it is not good, but this is going to happen. Be ready for it. Unfortunate, but yes, there would be difficult seniors who would not be satisfied by your work. They would never praise you. They would tell you that you should never have joined residency. You're a piece of shit. You don't know anything. You should go back to your home. There would be bad outcomes. You would lose patience. You would have stress from family relationships. You would have breakups. It's tough. The feeling of not being enough, it would be there. But this is how residency is going to be. You need to have that one good person to talk to whom about, and each of these builds resilience. So just this last slide on how to stay mentally healthy. You have to sleep whenever you can. This is my junior sleeping in the OR on the table. You have to catch sleep whenever you can. You have to eat at regular intervals. Again, your nursing staff would be very handy. They would get in things. You have to keep at least one hobby alive. My hobby was medtech innovation. So I went to 3 hackathons in the 3 years. I would, for 2 days at least, just go to them, tell your HOD that you're interested. You get a leave, just go and come back and attend. You need to have a good person to whom you can vent, someone you trust. For me, he was my co-JR. You can have your girlfriend, your boyfriend, someone from another department, anyone. Don't isolate yourself. Don't tell yourself that, okay, this is very tough, this is going to be tough for me, etc. You have to be a sport. Surgeons should have a charismatic energy along him and her. So you have to be there. Don't isolate yourself. Be a part of celebrations. Go party, enjoy, get drunk, enjoy, do everything possible in a residency. Make memories because they would keep you going forward, and learn the power of saying I need help. This was me doing STS in my second year of residency. My senior, who was a surgical oncologist, he said that, okay, you go and do it yourself. But I said, no, sir, this is my first case. I need your help. And he's a third year MCH surgical oncologist, but he was there to help me out because he kind of, you just have to be polite and say that, sir, I need help. Please teach me. No one is going to say, I'll not teach you. They will teach you. But if you have that arrogance that, no, I know everything, I'm sorry, you don't know anything and you would not be able to learn. So there's some small points which you need to understand. And this is what I learned from my residency. No one is born confident. So all of the people who are right now worried that you don't know enough, I didn't know enough. I was I was not born with a lot of confidence. I'm not born surgeon. Hands come with time, you would know. Hard work compounds beautifully. Believe me, people say that not everyone gets enough hands. It was a hard work that you got hand. Maybe that is true, but most of my co-JRs of my batch, of my junior batches who have been hardworking, they get hands, they get to learn a lot. Seniors notice everything as a senior. I would notice you as a first and second year. Every case teaches you something. You would not realize when that learning would be useful to you. And failure is a part of becoming a surgeon. You would fail, you would have your patients dying, you would fail when you're not able to resuscitate someone. There would be mistakes you would do which would cost lives, and that is okay. You have to believe in the long term growth. Short terms would be stressful, but just be there, be resilient, and be a good surgeon. So, yes, this is my last slide, that residency will change you, not by making you stronger, but by making you realize that you already were. You, as all surgeons, whoever is watching right now, all of you are very, very strong, and you're just beginning one of the most meaningful journeys of your life. Give it everything. And I always say, and this is my tagline and my motto of life: off to something great. No matter what you do, what you achieve, you're always off to something great. So this was kind of my last slide, and I think I said enough. There's a lot in me which I wanted to say in the last 1 hour, and I said it everything. So yeah, prioritize your mental health, avoid common mistakes, survive the 3 months, and you'll be through. You would master the OT hands, words, ER basics, and everything. You would build a strong CV eventually, and I'll be there to support you. I'll be more than happy to support you. So if there's anything how I can help, I'll be more than happy. So I'll just pause now, and this was it from my end. I think I took 10-15 minutes extra, but I'll be more than happy if you can unmute yourselves now and speak out whatever you could gather from this 50 minutes. And I hope that I didn't bore you, and I'll be more than happy to have questions. Thank you so much. Please feel free to unmute. Please feel free to text, chat. So I know that I was able to resonate with some of you, and hopefully, you would be great surgeons up ahead.
Hi, sir.
Hi,
My name is Ajay.
hi.
I really loved your presentation right now. Like, it gave me a lot of confidence. And whatever you said, I mean, I really hope I am able to follow up and make sure that I implement whatever you told right now. And I hope to maybe meet you someday.
Thank you so much. I'll be more than happy to meet you all. I'm also working on my SS prep right now. This is the reason for my clean shaven look. I have to prepare for the interview. So yeah, but then this is how life is. Yes, hopefully we'll meet soon in maybe one of the conferences.
Yes. Thank you so much, sir. It was very inspiring and reassuring more than anything. But I think we're all very nervous right now, and this really helped. Thank you.
That's okay. You can be nervous right now, and uh, that's okay. I think it's good to be nervous at times in before your residency. But believe me, as surgeons, you would, as I just said, that it will make you realize that you already were strong, and it will not make you stronger. So you are strong. You would realize at the end of 3 years that probably you would realize qualities of yours which you never know and you don't know right now. I'll be more than happy to talk to you. That 28 people, please don't shy. I'll stop recording if you want, and you can just speak ahead. That's fine. Just go ahead. You can have an impromptu talk. It's already 12 past midnight, so it's fine. So,
Hello, sir.
yeah, go ahead, Nikhil.
Yeah, thank you so much for the session. It was really helpful. But I wanted to ask about I might get surgery at Central Institute, but
Hmm.
I'm worried that I might get lesser hands-on as compared to state, I mean, government medical colleges. So, what are your thoughts about that?
Hi, Nikhil. So basically, not all central institutes provide the same hands. But again, you have to realize that you don't want to become a butcher. What happens in a central institute is kind of very systematic hands, is what I would say. You would not get something more than what you deserve. You would not get something less than what you deserve. So you kind of only get hands in a central institute when I can trust you that you know the intra post op and you can manage the intra, you know the pre-op and post op and you can manage the intra. So that is how I am as a senior, and my juniors have got immense hands. I can share my logbook. There are more than 500 cases which I've done independently. There are many cases which I've done. So again, it's very relative. I don't want to say that because I got hands in a central institute, so everyone does get. But hands-on should not be the only criteria. See, at the end of 3 years, you would realize that you have a more sorted residency. There is less amount of scut work. You would have a better pay. You would also have a better hostel life. So these things also matter at the end of 3 years. It's not just about hands. And at the end of 3 years, again, everyone would be sitting at the same place. No matter how much hands I got, no matter what hand someone got at some peripheral state institute or a DNB institute, all of us are again competing for that one SS seat. So it does not really matter. You just have to be happy with what you're getting and not crib along the 3 years. If you are content that, okay, I got this and I'm happy in what I got, that's fine. You would learn eventually. Learning is a phase, it will go on. So maybe
Thank
my,
you so much, sir, for
uh-huh.
this information. And again, I wanted to ask about research at AIIMS. So I
So,
want to
so
get
Nikhil,
more
Nikhil,
involved.
I really want to take another session. So there are two more sessions which I plan. One is on research and conferences, and one is maybe some basic teaching you some basic ABG and stuff. So maybe we can talk more on that because it's impossible for me on how to do research taking on this session. I hope you understand.
Yeah, yeah, thank you.
Meghna asks, can I talk a little on the MS surgery program at AIIMS Patna? It's a good program. We have got super specialty rotations in all the main super specialties in our second year. There is now a separate ICU as well. Uh, Again, it depends on who are you posted under, who are your seniors, and it kind of applies to all the colleges. It's a very good program. At least I really loved it, and I would definitely advise you to take it. But again, it again depends on where you're from, what are your future goals. So preparing for MRCS during residency just to enhance your CV. See, it's not about enhancing CV. MRCS is probably one of the best and the most, I would say, most creative exam I've given. It is the, after even passing my MS finals, I realized I don't know a lot of stuff because MRCS tests you on the basics, the basic anatomy. There were 150 anatomy questions in the part A. You realize 150 anatomy questions. You read just five. You read all your anatomy just to ace those 6 to 7 anatomy questions in a NEET, PG, and INI, and they were just very basic. Those same cranial foramens and some basic nerve tests. But imagine you have to give 130 MCQs on just core anatomy. And if you don't know anatomy, you cannot be a good surgeon. So you should give your MRCA just to read anatomy all over again and fall in love with the subject. And you can do it in your second year. So for me, surgery was the branch for me. It was in my second year. I scrubbed in for an OR, and I had a professor, Professor Ramanuj Mukherjee sir, in my second year of residency. Also in my third year of residency, I attended Dr. Ron Khandelwal sir's live class. That there was dams at that time where he used to teach. So all of these kind of played a huge role. Also in my internship, I did a good amount of hands-on. Like I did some appendectomies, I did some central lines and some venous cut down. So all in all, I think it was always surgery for me, and there was nothing else. I just love the adrenaline. Even I love the adrenaline even now. There's nothing else which fascinates me more than surgery. So my thesis topic selection was again on hernia because I was too much fascinated on hernia. There are a few pictures I would like to share probably in the next upcoming uh, uh, presentations. There was one picture in which I have a picture with the Liechtenstein Clinic, and Dr. Professor David Chen is there. He is the current head of Liechtenstein Clinic. What you read about the Liechtenstein hernia repair. And after meeting him and being a part of the hernia conferences, I realized it was hernia which I wanted to do. So I did a hernia thesis topic. Again, it all depends on who's your guide, what your guide does regularly, and what are the cases which is done regularly at your place. The platforms you to use for research, there are a lot of platforms. I can take them. Have taken them in a previous session on AI in research. You have Open Evidence, you have Scopus, you have um, there are a few others. Like I'll get back to you on that as well. So yeah, I think there are enough of questions. Please, I'll be more than happy to talk if anyone wants to unmute and say anything. There are 28 people still.
Sir, I have one more question.
Yeah, Jaguar.
Mm. So now let's just say that I get a peripheral government college right now
Yeah.
through my All India counseling. How do I attend those conferences? Because now, since you are in a central institute, I think they do let you take more leaves and focus more on conferences also. But how do I do that in a peripheral college, like a government medical college?
Yeah. So that is a very valid question because in a peripheral government college, you might not get a lot of leaves for these conferences because your seniors would say, "मैं तो कभी नहीं गया, तुम कैसे जाओगे?" kind of thing. You might have to lie at times. You might have to figure out those 2 or 3 good conferences which you want to attend. And believe me, the best part or the best way how you can get and attend those conferences are to hunt good cases in your first and second year, do some good research work, and just send your abstracts to these conferences. When they accept your abstracts, which they will 100%, and then you go to your HOD and say that, sir, I had also given your name and it is now accepted for a podium presentation or a plenary presentation, so please allow me to go. And I'm 100% sure your HOD or your HOU will allow you to go, or your guide will allow you to go, because all these professors, they might not go themselves, but they would love to have a certificate in their name that their work was published or presented somewhere. So that is one good hack which I have told many of my juniors. but there are some good state conferences which you can go. And I think for anyone, you have to attend one state and one national conference in your residency, because else you're not eligible for the final exam. So most of the people attend the state conference and the ASICons. You can do that if you want.
Thank you, sir.
Umar is also watching. I remember Umar being very vocal the last time we met. Umar Farooq, if you really want to go ahead and speak something.
Hi. No, see, most of the questions are already being answered.
Yeah,
So,
okay.
and this
Uh,
is an amazing presentation that we've had.
Pardon?
This was a really amazing presentation that you had.
Thanks,
It's
Umar.
very insightful, like, very eye-opening. Thanks a lot.
Thank you. So I think that was it from my end. I hope I was able to resonate with all of you, and I end it here. We all need to catch sleep. At least catch your sleep now before you join your residency. Catch good amount of sleep. Spend time with your family. Tell your girlfriend, your boyfriend that is going to be tough. So stick around, at least for the first few months till you get to figure out your residency better, and it will take you a long way. So yeah, thank you so much for joining in. This is what I wanted to do for a long time. I kept on delaying it because of my SS exams, but I had to do it one day or the other. And just be there, be hungry, and you will earn your OTs one day. Thank you so much. Bye bye. Take care. Good night.
Thank you, sir.